It took exactly 72 hours for a faint, easily ignored tingling in the toes to travel upward and entirely extinguish a healthy patient's ability to walk. The biological distance between the initial trigger and this profound paralysis was vast, yet the culprit itself turned out to be a remarkably ordinary meal consumed 3 weeks prior. Tonight brings two distinct clinical cases charting the slow, creeping loss of human motor control. Both medical histories document the quiet, systematic breakdown of the peripheral nerves, mapping how a simple sensation of heavy feet transitions into total immobility. There is no need to memorize the underlying pathology or track every diagnostic detail as these medical timelines unfold. You are entirely free to follow the clinical threads for only as long as you wish, letting your attention drift into sleep whenever the time feels right. The medical interventions are methodical and steady, ensuring that nothing in these records will startle you awake. The slipping grip. The onset was slow, almost imperceptible. It began with a faint tingling in the toes, a sensation easily dismissed as tired feet or shoes laced too tightly. But the tingling persisted, gradually shifting into a strange and constant numbness. When walking, there was a feeling of stepping on thick, soft cushions, as if layers of heavy cotton had been placed between the soles of the feet and the floor. This is a classic sign of sensory nerve damage. The delicate nerve endings responsible for feeling pressure and the texture of the ground were beginning to lose their ability to transmit clear, crisp signals back to the brain. Over the course of several months, that cotton wool sensation crept higher, moving past the ankles and settling into the calves. Then came the weakness. Legs that had carried groceries and climbed stairs for decades grew heavy and uncooperative, requiring immense effort just to cross a room. The hands were next to fail. Fingers grew clumsy, struggling with the small, everyday tasks of buttoning a shirt, turning a key in a lock, or holding a coffee cup. A grip would hold firm one moment and inexplicably release the next, objects slipping silently from the hands. The decline was steady and unrelenting. A walking cane became necessary for balance, followed rapidly by a walker, and eventually the necessity of a wheelchair. When examined in the neurology clinic, the physical findings painted a very specific picture of damage within the central nervous system. The physician used a tuning fork, placing the gently vibrating metal against the joints of the toes and ankles. The patient could not feel the vibration at all. This tested a specific sensory highway in the back of the spinal cord that carries information about vibration and position. Without this pathway functioning properly, the brain loses track of where the limbs are in space, a state called a loss of proprioception. Furthermore, when the doctor tapped the knees with a rubber hammer, the legs jerked outward with an exaggerated, forceful kick. This overactive reflex, combined with the profound weakness in the muscles, indicated that the main nerve highways descending from the brain through the spinal cord were actively under attack. Based on this examination, the initial diagnosis was an aggressive, progressive form of multiple sclerosis. It was a deeply sensible conclusion. Multiple sclerosis is a condition where the body's own immune system mistakenly attacks myelin. Myelin is the fatty, protective coating that wraps around nerve fibers, functioning very much like the thick rubber insulation encasing a delicate electrical wire. When that insulation is stripped away, the electrical signals traveling down the nerves short-circuit, slow down, or stop altogether. The symptoms of creeping numbness, progressive weakness, and overactive reflexes all perfectly matched the pattern of a disease eating away at this vital nerve insulation. The imaging studies seem to confirm this initial hypothesis. A magnetic resonance imaging scan, or MRI, of the spinal cord revealed bright, glowing spots within the delicate tissue of the neck and upper back. To a radiologist, these bright spots indicated areas of inflammation and scarring, places where the myelin had been damaged and water had rushed into the surrounding tissues. In the context of a patient steadily losing control of their limbs over a matter of months, these patches of damage on the MRI are exactly what doctors expect to find in a demyelinating disease. The medical team prepared to treat a chronic autoimmune condition of the nervous system. Yet, buried within the routine laboratory tests drawn on the morning of admission, there was a quiet anomaly. The blood work showed a significant drop in the number of red blood cells, which carry oxygen, as well as a steep decline in white blood cells, which are needed to fight infection. Multiple sclerosis is a disease entirely confined to the brain and spinal cord. It strips the insulation from nerves, but it does not interfere with the bone marrow, the spongy tissue inside our bones where all blood cells are continuously manufactured. The suppressed blood counts sat there on the chart, a small, subtle inconsistency in an otherwise seamless clinical picture. The suppressed blood counts sat there on the chart, a small, subtle inconsistency in an otherwise seamless clinical picture. To understand why this quiet detail changed the entire trajectory of the patient's care, it helps to look closely at the relationship between the brain, the spine, and the bone marrow. When a patient is admitted with profound, advancing weakness and imaging that shows damage to the spinal cord, a diagnosis of multiple sclerosis offers a complete and logical explanation. The immune system has mistakenly identified the protective coating of the nerves as a foreign threat and begun to dismantle it. But the immune system itself, the vast network of white blood cells that patrols the body, is born in the bone marrow. The bone marrow is the heavy manufacturing center of the human body, a deep, spongy network hidden inside the cavities of our largest bones, like the pelvis and the femurs. Every single second, this marrow produces millions of new red blood cells to carry oxygen and millions of new white blood cells to fight infection. For the bone marrow to fail, or even to slow down as it had in this patient, there usually has to be a structural problem within the marrow itself, or a critical shortage of the raw materials needed to build those cells. Multiple sclerosis does not alter the supply lines to the bone marrow. The medical team recognized that they were no longer looking at a disease confined to the nervous system. They were looking at a systemic failure, a condition where both the insulation of the spinal cord and the manufacturing center of the blood were breaking down at the exact same time. When these two specific systems falter together, doctors are trained to look for a missing building block. Both the creation of healthy blood cells and the maintenance of the myelin sheath around nerves require a very precise, steady supply of specific nutrients. The most common culprit for this dual failure is a severe lack of vitamin B12. Without it, the spinal cord begins to fray in a pattern that looks nearly identical to multiple sclerosis on an MRI, and the bone marrow produces fewer, larger, and less effective red blood cells. Naturally, the medical team ordered a test of the patient's vitamin levels, fully expecting to find a profound B12 deficiency. The results returned completely normal. The patient had plenty of vitamin B12. The investigation had to move past the common vitamins and into the realm of trace minerals. These are the elements of the earth that our bodies require in microscopic amounts to function. Iron is the most famous of these, but there are others, quietly keeping the machinery of the body turning. One of the most vital and most easily overlooked is copper. In the human body, copper does not act as a building material like calcium in bones. Instead, it functions as a catalyst. It is an essential component of several specific enzymes. You can think of enzymes as specialized workers on an assembly line, proteins that speed up chemical reactions that would otherwise take years to occur. There is a specific enzyme responsible for weaving together the fats and proteins that make up the myelin sheath around the nerves. That enzyme cannot do its job without a single atom of copper at its center, acting like a key in an ignition. In the bone marrow, a different copper-dependent enzyme is required to transport iron and help mature newly minted blood cells. Without copper, the assembly lines in both the spinal cord and the bone marrow slowly grind to a halt. Because we need so little of it, a natural copper deficiency is incredibly rare. We easily consume enough of it in everyday foods like nuts, seeds, grains, and seafood. The body has evolved a highly sophisticated system for extracting just the right amount of copper from our food and safely transporting it into the bloodstream. The mechanics of this extraction are elegant, taking place in the winding, darkened corridors of the small intestine. The lining of the small intestine is not smooth like the inside of a pipe. It is textured, covered in millions of microscopic, finger-like projections that wave gently in the passing fluid. This structure vastly increases the surface area available to absorb nutrients, creating a landscape that resembles deep, plush velvet. The cells that make up this velvet lining are the ultimate gatekeepers of the body. Everything we consume must be processed by these cells before it is allowed to enter the bloodstream. When you eat food containing trace minerals, these lining cells absorb the minerals and prepare to pass them along. But heavy metals like copper cannot be allowed to float freely within a cell. If they do, they can react with oxygen and cause damage to the delicate internal structures. To manage this, the gatekeeper cells manufacture a specialized holding protein. You can imagine this protein as a molecular sponge, designed specifically to bind to heavy metals, neutralizing them and holding them safely until they can be packaged and shipped into the blood. This holding protein is versatile. It is designed to bind to copper, but it also binds to another essential trace mineral, zinc. Zinc and copper travel the same pathways. They are absorbed by the same gatekeeper cells in the intestine, and they are managed by the exact same sponge-like holding proteins. Under normal circumstances, the body carefully balances the absorption of these two metals. However, the holding protein has a strong structural preference. Given the choice, it binds to copper thousands of times more tightly than it binds to zinc. This preference is a quiet, microscopic detail, but it is the fulcrum upon which this patient's entire mysterious paralysis rested. The physiology of this system is robust, but it can be overwhelmed if the balance of incoming materials is drastically altered. If a person were to ingest a massive, continuous excess of zinc, far beyond what any normal diet could provide, the gatekeeper cells in the intestine would detect the flood of this heavy metal. Sensing a potential toxicity from all the free-floating zinc, the cells respond by reading their DNA and manufacturing vast quantities of the sponge-like holding proteins to soak it up. The velvet lining of the intestine becomes absolutely saturated with these sponges, all deployed to capture the incoming zinc. And they do their job, binding the zinc safely, but the patient is still consuming regular food, which contains normal, trace amounts of copper. When that copper enters the intestine, it encounters an overwhelming number of these holding proteins. Because the proteins inherently prefer copper, they instantly drop the zinc they are holding and snatch up every single atom of copper that passes by. The copper becomes tightly locked inside the holding proteins, trapped within the gatekeeper cells of the intestinal wall. It is never packaged, it is never shipped into the bloodstream. The final step in this physiological failure involves the life cycle of the intestinal lining itself. The environment of the digestive tract is harsh, highly acidic, and constantly moving. Because of this wear and tear, the cells lining the intestine have a very short lifespan. Every 2 to 3 days, the older cells naturally detach from the wall, harmlessly falling away to be replaced by new cells from below. When those older cells detach and are swept away through the digestive tract as waste, they carry everything inside them. All the sponge-like proteins and all the tightly bound copper trapped within them are lost from the body. Through this quiet, invisible mechanism, a massive excess of zinc effectively blockades the borders of the body. The patient can eat plenty of copper, but the vast army of holding proteins in the gut traps it all, and the natural shedding of the intestinal lining carries it away. The blood is starved of copper while surrounded by it. Over a period of months or even years, the body's deep reserves of copper, mostly stored in the liver, begin to drain. Eventually, the reserves run dry, the assembly lines shut down. In the marrow, the young blood cells fail to mature, dropping the patient's red and white blood cell counts. In the cervical spine, the maintenance of the myelin sheath simply ceases. The insulation around the nerves begins to fray and break down, allowing fluid to accumulate and creating the bright, glowing spots on the MRI. Without that insulation, the electrical signals from the brain to the legs weaken, falter, and finally fail to arrive, slowly confining the patient to a wheelchair. Realizing that this entire cascade of systemic failure could be explained by a single missing trace element, the neurologists sent a new series of blood tests to the laboratory. They asked for a careful measurement of the heavy metals in the patient's blood. When the results returned, the picture was unmistakable. The amount of copper in the patient's bloodstream was so low it barely registered on the laboratory's instruments. It was a profound, life-threatening deficiency, and right beside it on the report, the level of zinc in the patient's blood was abnormally, wildly high. The medical team finally had the correct mechanism. They knew exactly how the nerves were being damaged, and they knew exactly why the bone marrow was struggling. But this knowledge only replaced one mystery with another. The body regulates zinc very efficiently, and the amount required to force the intestine into this sort of copper-trapping overdrive is staggering. The investigation now shifted from the microscopic world of cellular biology to the daily, routine life of the patient, as the doctors searched for the hidden, everyday source of this overwhelming flood of zinc. The medical team began by looking at the most common culprits. They asked about daily vitamin supplements, as many over-the-counter multivitamins contain high doses of zinc. The patient took none. They inquired about cold remedies, specifically the lozenges or nasal sprays that sometimes rely on the mineral to shorten the duration of seasonal illnesses. The patient rarely used them. The doctors then broadened their search to the environment. They considered whether she had been exposed to galvanized steel, which is coated in zinc to prevent rust, or whether there was a history of working in industrial welding. The patient had lived a quiet, largely indoor life, far from factories or metalworking shops. The elevated levels of zinc in the blood remained a stubborn fact, lingering in the medical charts without a clear source. The breakthrough came not from an advanced imaging scan, but from a simple, unhurried conversation. On a quiet afternoon, a neurologist sat by the patient's bed and asked her to describe a typical day, hour by hour, starting from the moment she woke up. They spoke about breakfast, about getting dressed, and about the small, ordinary routines of morning care. When the conversation turned to dental hygiene, the patient mentioned her false teeth. Her dentures were old, and they had not fit properly for quite some time. As she had gradually lost weight over the years, the shape of her gums had changed, leaving the rigid dental plates loose and uncomfortable. To keep her teeth firmly in place, and to avoid the quiet embarrassment of them slipping while she spoke or ate, the patient relied on an over-the-counter denture adhesive. The neurologist gently asked how much of the product she used. The patient explained that because the fit was so poor, a thin line of the paste was no longer enough. To create a secure seal, she applied thick layers of the adhesive multiple times a day. A single tube of the cream, which was designed to last a month or more, was being emptied every 3 or 4 days. This small, mundane detail held the answer to the entire medical mystery. Many popular denture creams rely on heavy metals to create a strong, temporary hold. Specifically, they use a zinc compound to form a waterproof grip between the plastic palate and the soft tissue of the gums. As the patient went about her day, eating and drinking with this thick layer of paste in her mouth, she was continuously swallowing small amounts of the adhesive. Over several years, she had been unwittingly consuming massive, continuous doses of zinc. This steady intake flooded her digestive tract, triggering her intestinal cells to produce the proteins that trapped copper and prevented it from entering her bloodstream. With the source finally identified, the medical team could formally name the condition. They diagnosed her with zinc-induced copper deficiency, myeloneuropathy. Medical terminology often sounds complex, but it simply describes a sequence of events and the location of the damage. The first part, zinc-induced copper deficiency, was the root cause. The second part, myeloneuropathy, described the result. In this word, the prefix myelo refers to the spinal cord, neuro refers to the long peripheral nerves stretching down into the legs and arms, and pathy indicates disease or damage. It was a precise description of a nervous system starved of the copper it needed to maintain its myelin sheath, the soft, protective insulation that wraps around the delicate electrical pathways of the nerves. The treatment began with an act as simple as throwing away the tubes of denture cream in the patient's bathroom cabinet. To bypass the zinc that was still blocking her digestive tract, the doctors administered copper directly into her bloodstream through an intravenous line. They provided these gentle, steady infusions over several days, giving her body the raw trace element it had been missing for so long. Once the zinc levels in her stomach and intestines began to fall back to a normal range, she was transitioned to a simple daily oral copper supplement. Her recovery proceeded at 2 different speeds. The bone marrow, which constantly turns over and creates new cells, responded beautifully and promptly. Within a few weeks, the patient's severe anemia reversed itself. Her blood counts rose, bringing healthy color back to her skin and returning a baseline level of energy to her days. The nervous system, however, heals much more slowly, and some of the long-standing scarring in the spinal cord was permanent. The patient did not regain all the function she had lost, but the terrifying, steady progression of her paralysis came to a complete stop. With time and physical therapy, the numbness in her hands began to fade, and she regained enough strength in her legs to transition out of the wheelchair, relying instead on a walker to move comfortably around her home. This case reveals a quiet truth about the nature of medical diagnosis. While modern medicine possesses extraordinary tools to look deep into the cells and the microscopic chemistry of the human body, the final answer often resides in the unremarkable habits of everyday life. Solving a difficult case frequently depends less on a moment of clinical brilliance and more on the patience to sit and listen to the ordinary details a patient considers too minor to mention. The sweet paralysis. The transition from normal life to profound weakness did not happen all at once. It began as a strange, heavy sensation in the lower legs, a feeling often compared to wading through waist-deep water. Over the course of a few days, this heaviness crept upward. Simple tasks, like rising from a chair or lifting an arm to reach a shelf, required intense concentration and effort. The muscles simply refused to answer the quiet instructions from the brain. By the time the man arrived at the emergency department, his legs could no longer bear his weight. He was in late middle age and otherwise entirely healthy, with no history of chronic illness or prolonged hospital stays, which made this sudden, quiet loss of function all the more unusual. In the examination room, the physician noted a presentation that was both still and severe. When the doctor gently tapped the patient's knees and ankles with a reflex hammer, the expected sudden kick was barely a tremor. The muscle tone in his arms and legs was completely loose, a state known in medical terms as flaccid paralysis. The tissues themselves were perfectly intact, undamaged by any injury, yet they were sitting completely idle. While the patient was experiencing this profound stillness, the monitors beside the bed painted a very different picture of his internal state. His blood pressure was strikingly elevated. It was at a level that typically causes severe headaches, blurred vision, or confusion, yet he felt only the creeping exhaustion. An electrocardiogram, which traces the electrical rhythm of the heart on a moving strip of paper, showed a slow, flattened pattern. After every beat, the heart was taking far too long to reset itself, struggling to complete its internal electrical cycle before the next beat could begin. Routine blood tests quickly revealed the underlying mechanism of this paralysis. The patient's potassium levels were dangerously low. Potassium is a vital mineral that acts as a kind of chemical battery for the cells. It sits inside the muscle tissue and helps carry the electrical spark from the nervous system. When a nerve tells a muscle to contract, the tiny pumps that move salt across the cell wall open up, and potassium flows outward to complete the circuit. If there is not enough potassium available, the nerve can send its signal, but the muscle will never receive the message. The heart is a large and highly sensitive muscle, which explained why it was laboring to maintain a steady rhythm. The medical team now had two distinct, significant clues. They were looking at severely high blood pressure paired with profoundly low potassium. In the landscape of diagnostic medicine, this specific combination of findings points a clear arrow toward one particular condition. The doctors reasonably suspected a small, localized growth in the adrenal glands. The adrenal glands are two small, triangular organs that sit like tiny caps on top of the kidneys. They manufacture several essential chemical messengers for the body. One of these is a hormone called aldosterone. Aldosterone functions as a manager of the body's salt and water balance. When the body needs to raise blood pressure, the adrenal glands release aldosterone into the bloodstream. This hormone travels down into the kidneys and delivers a specific set of instructions. It tells the kidneys to hold onto sodium, which keeps water in the blood vessels and raises the pressure. In exchange for keeping that sodium, it tells the kidneys to throw away potassium into the urine. Normally, this delicate trade is tightly controlled. However, a small, benign tumor can sometimes develop on an adrenal gland. This tumor ignores the body's normal feedback loops and constantly pumps out aldosterone, a condition known as Conn's syndrome. For the physicians evaluating the patient, this diagnosis made elegant sense. An endless supply of aldosterone would explain the remarkably high blood pressure as the kidneys relentlessly hoarded salt. It would also explain the paralyzed limbs and the slow heart as the kidneys steadily washed the patient's potassium away. It was a neat, textbook explanation that accounted for every symptom. To confirm this diagnosis, the doctors drew another vial of blood to measure the exact amount of aldosterone circulating in the patient's system. They naturally expected the number to be highly elevated, reflecting an adrenal tumor working in overdrive. When the laboratory results returned, they showed something entirely different. The level of the hormone was not high. In fact, it was so low that the laboratory equipment could barely detect it at all. This finding completely dismantled the theory of an adrenal tumor. If the patient had a tumor endlessly producing hormones, his aldosterone levels would have been off the charts. Instead, the near-total absence of the hormone told a different story, one of a healthy body desperately trying to correct a severe internal imbalance. The human body is equipped with a network of microscopic pressure sensors located in the walls of the major blood vessels in the neck and the chest. When the patient's blood pressure began to climb to dangerous heights, these sensors stretched, firing urgent signals to the brain. The brain recognized the excessive pressure and the heavy burden of salt in the blood, and it responded exactly as it was designed to do. It sent chemical messengers to the adrenal glands, commanding them to halt all production of aldosterone. The system was trying to tell the kidneys to stop hoarding salt and stop dumping potassium. The adrenal glands were listening perfectly to these commands, shutting down their assembly lines and letting aldosterone levels fall to zero. The kidneys, however, were entirely ignoring the absence of the hormone. They were behaving exactly as they would if they were bathed in excessive amounts of aldosterone. The cellular pumps were working tirelessly, pulling sodium out of the urine and back into the blood, driving the blood pressure ever higher. At the same time, they were pushing the body's precious potassium out into the urine, starving the muscles of the electrical charge they needed to move. If aldosterone was not flipping the biological switches in the kidneys, the medical team had to find out what was. To understand the doctor's next line of reasoning, it is necessary to look very closely at the microscopic architecture of the kidney cells, and specifically at how chemical messages are received in the body. Hormones function much like physical keys floating through the bloodstream. They travel everywhere, washing over every organ and tissue, but they only cause an effect when they encounter a cell equipped with the correct lock, which biologists call a receptor. The receptor that controls the balance of salt and potassium is situated deep inside the specialized cells that line the miles of microscopic filtration tubes in the kidneys. When the right hormone finds this receptor, it binds to it, fitting perfectly into its intricate three-dimensional shape. This physical connection sends a signal to the cell's nucleus, turning on the biological machinery that builds the tiny pumps that move salt across the cell wall. Aldosterone is the designated key for this lock. It is precision-engineered by the body to fit this specific receptor perfectly, and its only job is to turn that key. However, nature is deeply conservative in its designs. It often builds its chemical messengers from the same basic materials, modifying a single structural template to create different tools. Aldosterone belongs to a family of hormones called steroids, which all share a similar structural foundation built from a scaffold of cholesterol. Because they share this underlying chemical skeleton, many steroid hormones look remarkably similar to one another. One of these close chemical relatives is cortisol. Cortisol is perhaps best known as the body's primary stress hormone, but it is also the hormone of wakefulness and energy. It handles a vast array of essential daily functions, from regulating the metabolism of sugars and fats to reducing inflammation and managing the sleep cycle. It is what peaks in the morning to help you wake up, and what spikes when you need sudden energy. Because it has so many jobs in so many different tissues, cortisol is produced in massive quantities. At any given moment, there is roughly 1,000 times more cortisol circulating in the bloodstream than there is aldosterone. Structurally, cortisol is almost an exact duplicate of aldosterone. It is so similar, in fact, that it can fit perfectly into the aldosterone lock in the kidney cells. This presents a significant, potentially lethal architectural problem for the human body. The kidneys are designed to listen to the quiet, careful whispers of aldosterone to make fine, tiny adjustments to the body's salt and water balance. But they are constantly flooded with the loud, overwhelming presence of cortisol. If cortisol can turn the same keyhole, and there is 1,000 times more of it in the blood, the kidneys should theoretically be locked in a permanent state of maximum salt retention. Every time a person woke up in the morning or experienced a moment of stress, their cortisol would surge, their blood pressure would spike to catastrophic levels, and their potassium would wash away. Clearly, in a healthy person, this does not happen. Evolution provided a brilliant, invisible defense mechanism to prevent this continuous short circuit. The solution lies in a specialized enzyme placed specifically in the kidney cells, standing right beside the salt-regulating receptors. An enzyme is a type of protein that acts as a tiny chemical machine. Enzymes are designed to find specific molecules, grasp them, and alter their structure, often snipping off atoms to change their shape so they behave differently. In the kidney cells, this protective enzyme acts as a tireless microscopic guardian. Its sole purpose is to intercept cortisol before it can reach the lock. As the blood delivers its heavy load of cortisol into the kidney tissue, the enzyme catches the cortisol molecules. With a swift chemical reaction, it removes a single, tiny cluster of hydrogen atoms from the cortisol structure. This minor alteration transforms the active cortisol into a harmless, inactive byproduct called cortisone. Cortisone is just different enough in its shape that it can no longer fit into the aldosterone receptor. It simply bounces off the lock, unable to turn the key, and washes quietly away into the bloodstream. Through this elegant system of continuous local conversion, the kidneys create a protective bubble around their salt-regulating receptors. They allow the massive, necessary waves of cortisol to pass through the organs safely, completely ignored by the delicate salt-balancing machinery. The lock remains clear and ready, waiting only for the rare, specific arrival of aldosterone to make its necessary adjustments. The system is a marvel of biological engineering, but it has a single point of vulnerability. Its stability depends entirely on that protective enzyme continuing to function without interruption. If that enzyme were to fail, or if it was somehow blocked from doing its job, the protective bubble would immediately collapse. Without the enzyme standing guard to alter its shape, raw, active cortisol would flood the inner space of the kidney cells. Because cortisol fits the lock perfectly, it would immediately bind to the receptors. Given the sheer volume of cortisol constantly circulating in the blood, the kidney receptors would be utterly overwhelmed. They would be activated continuously and powerfully. The cells would interpret this flood of signals as an emergency command to hold onto every single molecule of salt and water they could find, and to expel potassium as rapidly as the pumps could manage. This mechanical breakdown perfectly described the patient's condition. As the doctors traced the physiology, the disparate pieces of the puzzle aligned seamlessly. The patient's profound muscle weakness, the creeping paralysis spreading through his limbs, and his sluggish, failing heart were all direct consequences of his missing potassium. The dangerously high blood pressure was the result of his kidneys endlessly hoarding salt and water, expanding the volume of fluid in his circulatory system until the blood vessels were straining under the tension. Crucially, this mechanism finally explained the baffling laboratory result. The blood test had shown almost no aldosterone because the patient's body was responding exactly as it should to the rising pressure. The brain had sensed the dangerous volume of fluid, and it had correctly instructed the adrenal glands to shut down aldosterone production entirely. The feedback loop was working. There was no tumor. Instead, the patient was suffering from a phenomenon where the kidneys were being tricked. The salt-regulating receptors were being relentlessly activated by cortisol, bypassing the body's control systems entirely. The clinical picture pointed to a localized failure in the kidneys. The protective enzyme, the microscopic guardian that normally neutralizes cortisol, had stopped working. Cortisol was running rampant, acting as a powerful imposter, turning the keys and leaving the cellular pumps stuck in the activated position. Understanding the molecular machinery of the failure brought the medical team significantly closer to the truth, but it raised a new and entirely different question. The protective enzyme in the kidneys does not simply degrade or switch off on its own in an otherwise healthy adult. It is a stable, essential part of the body's infrastructure. For the enzyme to stop functioning so completely, something had to be actively interfering with it. Something had to be binding to the tiny chemical machines and blocking them from doing their work. Since the patient had no genetic disorders and no history of kidney disease, the doctors concluded that the disruption had to be coming from the outside. The patient was unknowingly ingesting a substance that carried a very specific, very rare chemical property. It had to be a molecule uniquely shaped to survive digestion, find its way to the kidneys, attach itself perfectly to the protective enzyme, and shut it down. The investigation now shifted from the internal landscape of cells and receptors to the external details of the patient's daily routine, searching for the quiet, invisible toxin he was carrying into his own body. The medical team returned to the bedside with a new strategy. Instead of ordering more complex blood panels or scheduling another series of advanced imaging scans, they simply pulled up a chair and talked with the patient about the mundane rhythms of his everyday life. They asked about herbal teas, dietary supplements, over-the-counter medications, and his favorite snacks. They walked through his routine in quiet detail, tracing his steps from the moment he woke up to the time he went to bed. For a long while, nothing in his recounting stood out as unusual. He ate normal meals, drank water and coffee, and took no unconventional health supplements. Then, almost as an afterthought, while discussing his afternoons at work, the patient mentioned a very minor, ordinary habit. He liked to keep a steady supply of dark, chewy candy at his desk and in his car to snack on throughout the day. He had been consuming several large bags of traditional black licorice every week for the past few months. To the listening doctors, this small dietary detail was the missing piece of the puzzle. Authentic black licorice is made from the root extract of the licorice plant, a flowering shrub native to parts of Europe and Asia. For centuries, its roots have been harvested and boiled down to create a distinct, deeply sweet flavoring used in confections and traditional remedies. But within that natural, earthy extract is a highly specific chemical compound known as glycyrrhizin or glycyrrhizic acid. When a person digests this compound, it travels smoothly through the bloodstream and arrives at the delicate filtration system of the kidneys. By a strange and unfortunate quirk of nature, the molecular shape of this sweet substance perfectly matches the shape of the protective kidney enzyme the doctors had been studying. The compound binds tightly to the enzyme, essentially jamming the cellular lock and preventing it from doing its essential work. With the enzyme completely shut down by the candy extract, the body's normal stress hormones were no longer being deactivated in the kidneys. Instead, they remained active and were free to bind to the salt-regulating receptors, overstimulating them continuously. The medical term for this condition is pseudoaldosteronism, which translates to a false overproduction of the salt-retaining hormone. This flood of unrestrained chemical signals forced the kidneys to stubbornly hold onto sodium. The retained sodium dragged excess water into the bloodstream, expanding the volume of fluid in his vessels and driving the patient's blood pressure to dangerous heights. At the exact same time, this continuous, unyielding signal forced the kidneys to rapidly flush potassium out of the body, discarding it into the urine. This constant, daily draining of potassium led to severe hypokalemia, the profoundly low potassium levels that ultimately drained the electrical energy from the patient's muscles and caused his sudden, terrifying paralysis. Once the mechanism was clearly understood, the treatment was remarkably straightforward and entirely non-surgical. The first and most important intervention was simply removing the invisible toxin from his diet. The patient was instructed to stop eating black licorice entirely, which would allow his body the time it needed to clear the remaining glycyrrhizic acid from his system. Over a period of several days, the protective enzymes in his kidneys would slowly become unblocked, waking up to resume their normal task of filtering and neutralizing hormones. While they waited for his internal chemistry to gradually reset itself, the medical team had to carefully replace the heavy mineral losses he had suffered. He was given slow, continuous intravenous infusions of liquid potassium. Replenishing this vital electrolyte must be done with great patience, as a sudden influx can overwhelm the heart muscle just as easily as a deficit can. Day by day, as the steady, measured drip of potassium restored the proper electrical balance in his tissues, the heavy, motionless feeling in his limbs began to lift. He first regained the ability to wiggle his toes, then to bend his legs, and finally to lift his arms. His blood pressure, which had previously been stubbornly high and resistant to typical emergency medications, naturally softened and returned to a safe, resting baseline. Within a couple of weeks, the patient walked out of the hospital under his own power, his strength entirely restored, leaving behind a medical chart that had transitioned from a life-threatening mystery to a completely resolved case. This progression from a paralyzed patient to a fully recovered one illustrates a quiet truth about the nature of medical diagnosis. The most profound insights often do not emerge from surgical explorations or advanced technology, but from the simple, patient act of taking a careful history. True diagnostic medicine relies on listening closely to the mundane details of a person's routine, recognizing that the extraordinary and the dangerous are sometimes hidden in plain sight. It is a gentle reminder that the boundary between our environment and the internal systems of our bodies is deeply porous, shaped just as much by our daily habits as by our biology. Whatever you remember of this in the morning is more than enough.